The second most common cause of anemia worldwide is anemia of chronic disease, also known as anemia of inflammation. And in this InstaLecture session, I will tell you a story and also three key concepts about anemia of chronic disease or anemia of inflammation. So let me begin with the story first. This story is about two friends, Ram and Sam. And this story is about one Friday evening. And this story is about what they did on that Friday evening. So on that Friday evening, Ram was very much exhausted. So he came back to his apartment and he went to his kitchen and he found that he has no raw material to cook because he didn't visit any shopping mall that weekend or grocery shop that weekend to buy any grocery products for cooking. So he called his friend Sam and he told that, do you plan to visit restaurant because I cannot cook at my home right now. So Sam tells, yes, exactly, I have the same kind of problem. You know what happened to me? I do visit I visited the shopping mall or grocery shops, but I kept them, all those raw materials for the cooking, I kept them in the fridge, refrigerator, and I locked them actually. And now I forgot the key. I cannot find out the key. So all my raw materials for cooking is locked up inside the fridge and I cannot access that. So I also need to visit the restaurant along with you. Now, if you see, in this case, in case of Ram's, the problem is that Ram didn't have at all the raw material, or in case what I'm trying to say, iron in the body. So he cannot produce RBC because iron is required for heme production, heme is required for hemoglobin production, and hemoglobin is required for RBC production. So if you don't have iron, you cannot produce RBC and enough iron. And in the second case, the case of Sam, the issue was a little bit different. That iron was there, but his raw material, his grocery items were he purchased, which was there, but it was locked up inside the fridge. Similarly, in some cases in the body, the iron gets locked up inside the reticuloendothelial cells or the macrophages. So the body, the RBC precursors, which require them to produce RBC, mature RBC, they cannot access them because it's locked up inside the macrophages of the reticuloendothelial cells, just like what happened in the cases of Sam. So again, the net outcome is the same, that they cannot produce the RBC effectively, and obviously that results in the anemia. So now the first point that you need to understand, that the case of anemia of chronic disease is quite similar to iron-deficiency anemia, but the issue is a little bit different. Here the body cannot access the iron effectively. This is one of the key reasons why that results in the anemia of chronic disease or anemia of inflammation. So as anemia of chronic disease, ACD, also known as AI, anemia of inflammation. AI, by the way, is not artificial intelligence, which you're thinking. In medicine, it means anemia of inflammation, also called anemia of acute and chronic inflammation. And in that case, anemia of inflammation, what happened actually, that it's usually seen associated with certain disorders, like it could be associated with some inflammation. Traditionally, it is thought that they are associated with certain disorders. Inflammation like rheumatoid arthritis, inflammatory bowel disorders like Crohn's disease, like some kind of chronic infection, tuberculosis, some autoimmune disorders like SLE. By the way, the most common type of anemia seen in SLE is not autoimmune hemolytic anemia, which many of you think in that way. The most common type of anemia seen in SLE is anemia of chronic disease or anemia of inflammation. And nowadays they have found that this anemia of chronic disease is also associated with a lot of other disorders like COPD, congestive heart failure. It could be seen in traumatic patients having traumatic injury. They are not confined into those things which are conventionally thought, that they are only seen in cases of infection or inflammation or cancers. And I forgot to mention that cancer is also one of the causes, like lymphoma, multiple myeloma, plasma cell myeloma, and also the solid cancers. They can be associated with anemia of chronic disease or anemia of inflammation. Yeah, this is our topic. So the first thing we learned that this is the second most common cause of the anemia, and what are the conditions which is associated with anemia of chronic disease, ACD or anemia of inflammation. The second thing, right now I'm going to explain that why anemia of chronic disease or anemia of inflammation occurs. And the third thing which I would explain is their manifestation. And the fourth thing which I would explain is how to differentiate it with its close differential diagnosis, that is iron-deficiency anemia. So now let's try to understand that why actually anemia of chronic disease occurs. What is the real problem? Why its pathogenesis part actually. Now, traditionally, it is thought that it's a kind of evolutionary strategy of the human beings, the body's development. Because when I'm affected by an infection, like by a bacteria, I don't want that the bacteria has the iron available. So that, because for many bacteria, the iron is necessary for their survival, uh, their prosperity, that is necessary. So if the body system basically tactfully cut out the availability of iron, so that the bacteria cannot access them. So obviously, if they cannot thrive, the infection would decrease. That is the idea. So that's why the availability of iron decreases during this thing. Now, the question is that how and why this occurs. Currently, it is now been found that this process is mostly cytokine mediated. What is cytokine? Cytokine is the way one cell talks with another. The cells in our body that don't have WhatsApp, Viber, or Instagram chat. So they need to talk with each other. So they usually talk each other with certain molecules like the cytokines. So now it has been found that there are certain cytokines which are basically driving the development of the anemia of chronic disease or anemia of inflammation. For example, one classic one is interleukin 6 along with interleukin 1, interleukin 22. They have been found to stimulate the secretion of a hormone from the liver, which is a master key regulatory hormone of the iron homeostasis in the body, that is hepcidin. So when the hepcidin is increased in amount from the liver, what does hepcidin do? Hepcidin acts in two ways. Firstly, one way is that they decrease iron absorption inside the body. But another major way which plays a crucial role, that they actually make the iron locked up inside the macrophages in the bone marrow or other place in the reticular endothelial cells. Because for a RBC precursor cells to access the iron when they are cooking the RBC, they basically can access from the storage, from the macrophages. But now there is one protein particularly known as ferroportin that get internalized or degraded by the presence of the increased hepcidin. So now the RBC precursor cells, they cannot access the iron which is there inside the macrophages. It's some kind of locked up and the key is missing. Just like I told in the story of the SAM, that all the cooking material or the raw material or the grocery products, they're locked up inside the fridge and the key of the lock is missing. Some kind like that. Second thing, it has been found that in cases of ACD or AI, anemia of inflammation, there is also increased storage occurs of the iron occurs inside the reticular endothelial cells or macrophages, because the body facilitates through the cytokines the increased storage. So they're making less iron available and making it more stored. Other than that, there's also nowadays, it has been found that this process of development of anemia of chronic disease is not so simple. It's only by cutting out the access of iron to the body system. It's not like that. There's many other things that also play a role. Like it has been seen that the erythropoietin production is decreased in the anemia of chronic disease. And that is quite disproportionate to the severity of the anemia. That means normally when there is a person is anemic, in a response, body actually produce more amount of erythropoietin, which is a hormone synthesized mostly from the kidney, to do erythropoiesis. That means erythro means red blood cell, poiesis means formation in the bone marrow, as the name suggests. But in this condition, now there is anemia, but there is less production of the erythropoietin. The erythropoietin is not produced in adequate amount as much as required. That has been said. And this is also suppressed by this erythropoietin production is also being suppressed by the cytokines that have been found. Now, the other thing that they have been seen, that there is a reduced RBC survival. That means RBCs, they usually survive reduced in this case. The number of days they survive, they decrease. And that is also thought to be some process by cytokine or the generation of some free oxygen radicals that basically causes early destruction of the RBCs. And also they have been seen that the response of the bone marrow to produce more RBC, that also becomes somehow decreased in the cases of ACT. So if I put all these things together, that means why this AI occurs. There are few reasons which we can compile. Firstly, body is strategically storing the iron, making it less available in the system. So it is initially, it is conventionally thought actually the evolutionary strategy of the body that to restrict the availability of the iron to the infection, because anemia of inflammatory disease, anemia of infection, obviously occurring when you have infection, and the body don't want that infection causing bacteria flourishes or thrives, because if it would flourish or thrive, there is more amount of iron available. So that's why they're doing that. This is one of the ideas. Second, I mentioned that there is increased amount of hepcidin, which is the master regulator of the iron homeostasis in the body, which is a peptide which is secreted from the liver. And as the name suggests, you can also understand that this is secreted from the liver, because hep means liver actually, and they have some bactericidal property. And hepcidin, when they're increased, they basically also restrict the availability of the iron from the reticuloendothelial cells, because those iron gets locked up inside the reticuloendothelial cells, because the key, which is the ferroprotein, that get degraded. So obviously the erythroid precursors, the RBC precursors, which require those iron from the reticuloendothelial cells, they cannot access them, just like the SAM story I mentioned. And I also emphasize right now that this process is not so simple, it's multifactorial. And the other factors which contribute to the development of anemia of chronic disease is reduced or shortened RBC survival, increased means I would say that increased concentration of the iron inside the reticuloendothelial cells. That means they're facilitating, the body is facilitating that the reticuloendothelial cells to store more amount of iron. There is decreased erythropoietin secretion, that means in other words, that is suppression of the erythropoietin secretion from the kidney, and the bone marrow becomes less responsive to the erythropoietin. So all these factors contribute altogether to the development of the anemia of chronic disease. The next thing I'm going to discuss, the next big concept, is how you can expect a patient with anemia of chronic disease present. The first key concept here, this anemia of chronic disease is usually not life-threatening by the anemia itself, actually, because anemia of chronic disease by definition would be usually mild or some cases moderate, but not severe. So normally you can get hemoglobin between the range of 9 to 11. And they have seen only around 20% cases it would be less than 8. The next big concept is this, that most of them cases of the anemia of chronic disease, they are normocytic normochromic anemia. In around 25% of cases, they can progress to develop as hypochromic microcytic anemia. Now, some places you might be reading that they are presenting with microcytic hypochromic, and some places you're reading normochromic normocytic. So the key concept that you need to understand that they can present both as normochromic normocytic as well as hypochromic microcytic. And basically majority of them, mostly they present with hypochromic normochromic normocytic, and in some cases which becomes the severe and there is less iron accessible to the RBC precursor cells, that would become hypochromic microcytic. Why? It's very simple to understand, because is this anemia is going to be hypochromic microcytic or normochromic normocytic is dictated by the availability of the iron, which I told you. Because ultimately RBC, as I always mention in this way, that RBC is nothing but a bag full of hemoglobin. And so the key content of that bag is hemoglobin. And to produce hemoglobin, you require iron, heme. So if you don't have too much deficiency of iron, so you could produce very little amount of hemoglobin. And if you put little amount of hemoglobin inside the bag, obviously the bag size would become smaller. And if you put more amount of hemoglobin, bag size would be relatively more. So depending on how much iron is locked up, how much iron is available, if it is very less available, so the size of the RBC would become smaller, because body is producing less amount of hemoglobin in the bone marrow and they're putting less amount of hemoglobin inside that bag. So obviously the bag size would shrink, it becomes smaller, and that's why you get microcytic hypochromic. Hypochromic means they become less red color, because obviously the same reason, because hemoglobin is the pigment which is imparting its red color. So if you have less hemoglobin inside a RBC, it will become less chromic or microcytic. So primarily, they present with normochromic normocytic anemia, anemia of chronic disease. But if the iron availability becomes very less, in that case, it could progress to as or present as hypochromic microcytic anemia. But usually, most of the cases, as I mentioned, the anemia would be mild to moderate, but not severe, usually in the range of 9 to 11, like that. The next thing that you need to understand of the anemia of chronic disease, anemia of inflammation, that the other cell series is usually not affected, like WBC cell series or the leukocyte cell series or the platelets are usually not affected by this anemia of chronic disease, anemia of inflammation. So they would be normal. They might be abnormal due to the, secondly, due to the disease process which is involved. Like SLE patient, they can have thrombocytopenia, but that thrombocytopenia is not due to anemia of chronic disease or anemia of inflammation. Thrombocytopenia is autoimmune thrombocytopenia because it's autoimmune disorder. So it by itself, anemia of chronic disease, they don't cause any alteration in the WBC or the platelet cell series. But if any alteration is occurring, that you need to think about, it's occurring due to secondary, due to the disease itself. That is the idea. Now, the next big concept that you need to understand that how to differentiate it from its closest differential diagnosis, that is iron deficiency anemia. So first think about few similarities, the similarities which are seen in the anemia of chronic disease or the iron deficiency anemia. The similarity would be that the serum iron would be low in both the condition. Transferrin saturation, it would be low in both the condition. But TIBC would be a differentiating factor. TIBC would be increased in the iron deficiency anemia, and TIBC would be decreased in the anemia of chronic disease. The idea is very simple, as I mentioned earlier also in another InstaLecture. I already explained the concept of TIBC. TIBC is basically directly indicating the amount of transferrin level. So if you have total iron binding capacity, the full name is basically total iron binding capacity of transferrin. And transferrin is iron carrier molecule. One transferrin binds with 2 iron molecules. So if you have more amount of iron transferrin available in your body, your total iron binding capacity in the body would increase. As simple as that. Now, in cases of iron deficiency anemia, total amount of transferrin is increasing in the body. So when your transferrin is increasing, the number of transferrin is increasing, the number of iron binding capacity of those transferrin, that is also increasing because each transferrin can bind with 2 iron molecules. So if you have in the body, suppose for example, 100 transferrin molecule, you can bind with 200 iron atoms. If you have right now 200 transferrin molecule, now you can bind with 400 iron atoms. So obviously your iron binding capacity would increase as your transferrin increases. Now in iron deficiency anemia, as the transferrin increases, that would cause increase in the total iron binding capacity. But transferrin do not increase in the cases of anemia of chronic disease. It could be decreased. And that's why the TIBC, total iron binding capacity, would be decreased in the cases of anemia of chronic disease. Now, another key area is ferritin. Ferritin level, which is a storage form of the iron, it's basically decreased in the iron deficiency anemia. Because obviously you have no iron. But in case of anemia of chronic disease, the ferritin could be increased and sometimes would be normal also, but not decreased, unlike the iron deficiency anemia. Why? It's also very simple to understand. Because ferritin is an acute phase reactant. So in inflammation or infection, the acute phase reactant level, they would increase. So this is one of the reasons where the ferritin level would be increased in the anemia of chronic disease or anemia of the inflammation. And it has also been seen in anemia of chronic disease, anemia of inflammation, that as there is a more storage form of the iron, and also the macrophages, they secrete more amount of this ferritin, the ferritin level would be increased. So why the ferritin level is increased in the anemia of chronic disease, this is also not by only one process, that is, it's an acute phase reactant, it's a multifactorial process. So now if I put all these things in a nutshell, that in anemia of chronic disease or anemia of inflammation, you would be getting low serum iron, you would be getting low TIBC, you would be getting low transferrin saturation. Low transferrin saturation because as there is a low serum iron, obviously less amount of transferrin would be saturated. There is a low transferrin saturation. And the serum ferritin level could be increased or normal in some cases also. But nowadays they have found a technical parameter that is many experts consider the best to differentiate anemia of chronic disease versus anemia of inflammation. And that parameter is soluble transferrin receptor by, this is a ratio between soluble transferrin receptor by log of serum ferritin. So I write it down for you actually to make it simple. This is nowadays considered the best parameter to differentiate between iron deficiency anemia, anemia of chronic disease. And this is a very simple concept to explain, actually understand. So I would make it simple for you. So this ratio, they say, that is sTfR, which basically stands for soluble transferrin receptor, divided by log of serum ferritin. If this ratio, value of this ratio, that means soluble transferrin receptor divided by log of serum ferritin, if the value of this ratio is more than 2, it is thought to be definitive for IDA, Iron-deficiency anemia. And if this the value of this ratio is less than 1, this is for ACD, anemia of chronic disease, or also known as anemia of inflammation. Why? I would explain this concept right now. Now, these soluble transferrin receptor, what are they? Soluble transferrin receptors are basically the receptor for transferrin which are expressed on the RBC precursors or the bone marrow. And it has been seen that in the iron deficiency anemia, that there is increased number of expression of the transferrin receptors over the bone marrow thread precursors. So that means something like this, that these are thread precursors and they're expressing some molecules over their surface, that is transferrin receptor, TFR. And some amount of this transferrin receptor gets truncated and also available in the serum, and we can measure them. And as they're increased in cases of iron deficiency anemia, this is another feature, and they would be decreased in usually cases of anemia of chronic disease and inflammation, which is basically cytokine mediated suppression. So if you see in a fraction or in a value actually, that the soluble in this fraction, actually the soluble transferrin receptor, their level is basically increased, and which is divided by log of serum ferritin, and serum ferritin level would be decreased in the cases of iron deficiency anemia. So obviously if you think mathematically that in this fraction, that is sTfR divided by log of serum ferritin, sTfR is increasing in iron deficiency anemia and log of serum ferritin is decreasing in iron deficiency anemia. So their value would be more than 2, higher, obviously. In case there would be more than 1, in this case it would be particularly more than 2. And in case of anemia of chronic disease, this value would be less than 1. Why? It is very simple to understand, because in ACD or A1, soluble transferrin receptor is decreasing, but serum ferritin is increasing. So if in a fraction, if the upper portion actually that are decreasing in a fraction, the upper portion is decreasing and the lower portion of in the fraction actually they are increasing, what would happen? The value would decrease, the value would become less than 1. So that is the reason why ACD or AI, the value would be less than 1. I'm again repeating this concept so that you understand. You need to understand that currently the best way to differentiate them, they say, technically is by a ratio, which is soluble transferrin receptor divided by log of serum ferritin. So this is the ratio. Soluble transferrin receptor divided by log of serum ferritin. We write it in this way, sTfR divided by log of serum ferritin. Serum ferritin. So in cases of iron-deficiency anemia, this transferrin receptor or the soluble transferrin receptor, they increase, and serum ferritin, they decrease. So the total value of this fraction, it becomes higher. And in the cases of iron-deficiency anemia, they become more than 2. So that is characteristic of iron-deficiency anemia. But in case of anemia of chronic disease, anemia of inflammation, this transferrin receptor, the soluble transferrin receptor, they decrease because cytokines suppress the expression of the transferrin receptor over the erythroid precursors. And also, in cases of anemia of chronic disease, anemia of inflammation, ferritin level is increasing. So in a fraction, if the upper portion decrease and the lower portion increase, the value basically of the fraction would decrease. So that's why in cases of ACD or anemia of chronic disease or inflammation, you'd be getting less than 1, this ratio. So these are the key nowadays, this parameter, the soluble transferrin receptor by log of serum ferritin will be help you to differentiate anemia of chronic disease or anemia of inflammation. Now, let me clear this and discuss few other concepts which I mentioned there. That what are the other parameters other than this to differentiate anemia of chronic disease from anemia of inflammation? So obviously, first point I told you that iron deficiency anemia would be always the microcytic hypochromic typically they would be presenting with. And anemia of chronic disease, anemia of chronic disease, or anemia of inflammation, they can have both normochromic, normocytic, anemia and hypochromic microcytic anemia. And majority of them, they have normochromic, normocytic anemia. Another key concept I would like to tell you that if they have microcytic hypochromic anemia, their MCV values would not be too low. Like normochromic, normocytic, the MCV values is between 80 to 100 femtoliter. If their anemia of chronic disease patients are developing hypochromic microcytic anemia, they would be hovering in the range of 70 to 80 femtoliter, but not as low as like 20, 30. But in case of iron deficiency anemia, MCV values could be very, very low. But that would not be seen in cases of anemia of chronic disease. Anemia of chronic disease, the MCV value would be, some cases I mentioned, 20% cases, they can, 20-25% cases, they can develop hypochromic microcytic anemia. But in that cases, the MCV value would be just a little bit low than the normal level. That is another parameter. And then I discussed about certain similarities between the iron deficiency anemia and the anemia of chronic disease. The similarity will be both the cases, there would be low serum ferritin and there would be low transferrin saturation. This is their similarity with iron deficiency anemia. But a key difference would be that TIBC would be decreased in ACD, which is the topic of the discussion. And also the ferritin level would be increased or normal in ACD. And also I mentioned that the ratio, that is the soluble transferrin receptor divided by log of serum ferritin, this ratio would be less than 1 in cases of ACD. So ACD, anemia of chronic disease, what you expect? You'd be expecting getting mild to moderate anemia. Most of the cases mild. The anemia type, subtype would be both normochromic, normocytic and microcytic hypochromic. Majority of them, they would be normochromic, normocytic. Some cases, they would be microcytic hypochromic. And I told if they develop microcytic hypochromic, the MCV would be not very much low. The MCV would be around 70 in that range, just a little bit less than 80 femtoliter. Then come to the iron study parameters. Iron study parameters, the serum iron would be low, because that is the body's basic strategy to cut off the availability of the iron to the bacteria and other things. So obviously the serum iron level would be low, and transferrin saturation would also be low because due to low iron. So there is less amount of iron available to bind with transferrin. So obviously the carrier molecule, so that's saturated, they would be less saturated. So obviously that would be low. So these two parameters, that is low serum iron and the low transferrin saturation, is just like iron deficiency anemia. But the key differentiating factors is that TIBC is high in the iron deficiency anemia and TIBC is low in the anemia of chronic disease, which I already explained many times in the previous InstaLecture. What is TIBC and why it is low with my hotel analogy or hotel occupancy analogy. And the next thing that you need to understand, that ferritin, as its acute phase reactant and also the storage form of the iron, level would be increased or also can be normal in the anemia of chronic disease. The ferritin level is typically decreased in cases of iron deficiency. And currently there is a best parameter there, that is the log of that is the soluble transferrin receptor, which is basically decreased in cases of anemia of chronic disease, and the ratio of soluble transferrin receptor divided by log of serum ferritin, that would be less than 1 in cases of anemia of chronic disease. So now if I summarize what we basically learned in this session, that anemia of chronic disease, which is also known as anemia of inflammation, anemia of acute or chronic inflammation, it's basically a process which is typically seen, conventionally thought to be associated with infection, inflammation, cancers. But nowadays, it's found that they could be seen in many other conditions like COPD, congestive heart failure, trauma, diabetes also. These many conditions could be seen. Second concept I mentioned, that why this occurs, I already explained that this occurs is basically due to multifactorial reasons. One reason is that as a part of evolutionary strategy, body, as there is an infection which may be present in the body want to cut off the availability of the iron. Secondly, it's a cytokine driven process. So cytokines like interleukin 1, interleukin 6, interleukin 22, these things, they actually can play a role, and also TNF, they can also play a role in this process. One of the key things they do actually to increase the secretion of the hepcidin. Hepcidin causes degradation and internalization of the ferroprotein, particularly in the macrophages of the reticuloendothelial cell. So what is happening, that this ferroprotein, as they're getting degraded or internalized, so the next problem which is actually happening, that these irons, though they're available in the bone marrow, but they're not able to access by the bone marrow cells. Bone marrow cells means RBC precursors. And then I also told you discuss about the summary, how they're different from each other. So all this is in a nutshell for the session on anemia of chronic disease. The further things I will discuss in the coming sessions. Thank you very much.